Good afternoon. My name is Dr. Janice Pasieka, and I'm an endocrine surgeon here at the University of Calgary. I'm sorry I couldn't make it to your meeting, but I understand it has been a big success over the last 2 days and that you are in the final stretches of finishing up. Jackie asked me if I would speak about cognitive issues in neuroendocrine patients. I've done a fair amount of research in this area, and it is an area that I am most curious about and have been trying to solve some of the issues around cognition in neuroendocrine patients. But I did see that on the program, I was also asked to provide mechanisms of dealing with cognitive issues in neuroendocrine patients. I'm a surgeon, and I am not authorized or capable of providing that kind of expertise. So if any of you in the audience are suffering from cognitive decline or cognitive impairment, reach out to your physicians at your local cancer center. There are many psychosocial support systems built into our cancer network across this country. In the spirit of truth and reconciliation, I would like to take this opportunity to acknowledge that I have the privilege of working and, most importantly, exploring the traditional territories of the people of Treaty 7 region in southern Alberta, as well as the Métis Nations of Alberta Region 3. It is the ability to explore these unceded territories that has helped keep me both physically and mentally healthy. I sit on a few advisory boards, including CNETs. My talk is going to leave you with more questions than answers, and I also would like to disclose that this presentation was made solely by human, without the use of artificial intelligence. My objectives are sort of two main areas. First, I want to bring awareness to the issue of cognitive impairment, not just in neuroendocrine tumors, but in patients suffering from a host of different cancers. I want to highlight the potential mechanisms that are now being explored in cancer patients and show how that the uniqueness of neuroendocrine patients, this could fit right into it. So cognition, what is cognition? Cognition is the mental process or action of acquiring knowledge and understanding through thought, our experiences, and all of our senses. So there are multitudes of domains that make up our cognitive function. It's not just one single entity. And these are a host of domains: our ability to concentrate, our attention span, the language that is being utilized, executive function, the ability to multitask, our motor function, our visual spatial skills, our memory, whether it's verbal or visual, and the processing speed of the information that we get from our environment. All of these are various domains of cognitive function. And if we disrupt any one of these, as a patient, you will experience cognitive dysfunction. So in Canada, the statistics are there were 234,000 new cancer patients diagnosed in 2022, and 1.5 million Canadians are living with cancer. In the United States, it's estimated that 4.5 million cancer patients are living with cognitive impairment. And that is because we've started to shift our focus from just a pure survival focus in cancer, and started to recognize that, yes, we're making great strides in curing and having patients survive, but now we have to look also at the therapeutic toxicities. And one of them has been defined as cognitive impairment. However, it's also among investigators felt that there is an underappreciation of the inherent cancer-related toxicities. The cancer itself has an effect not just on the organ from which it arose, but can also be part of cognitive decline. And that sort of comes from a multitude of studies, but they were summarized in a review article by Olson and Marks, where they estimated that 75% of cancer patients experience impairment, cognitive impairment, sometime during their treatment. This could be what people refer to as chemo brain. It could be because of their radiation treatments. 35% will develop impairment years out after the treatment. So they've survived, but now they have an accelerated decline in neurocognition. But what I want to focus is on the 30% of patients who have cognitive impairment prior to any treatment. Measuring cancer-related cognitive impairment, so CRCI, the impairment that is caused by the cancer itself, is very difficult to do because cognition, as we talked about, has a multitude of different domains. And cognition can be altered by stress, anxiety, fatigue, or sleep deprivation. It depends on the age and the educational level of the individual. Those also suffering from depression, coping factors, and comorbidities, all things that cancer patients, when given the diagnosis, will suffer from in some form, and not necessarily then related to the cancer itself. However, many investigators have looked at specific neurocognitive testing using neuropsychological assessments in a host of different cancers. And you can see here breast, colorectal, pancreas. And prior to any form of treatment, there was cognitive impairment found ranging from 23 to as high as 46%. So which one? What is being affected? Is it all of them? Is there certain ones that are more affected by different cancers? That's what we don't know. The International Cognition and Cancer Task Force then recognized this is an important piece of cancer therapy and has recommended that all studies that are clinical trials that are treating cancer patients incorporate formal neurocognitive testing prior to the treatment. And these are just a host of the ones they have recommended that would capture things like executive function, visual and spatial memory, and word processing. Unfortunately, they're very time-consuming and they can be expensive. And as you will see later in the talk, that can impair our ability to recruit patients. So many studies are using self-reported cognitive testing. The problem with self-reporting testing, when we ask you as an individual patient, how is your cognition? The perceived dysfunction actually may be higher than what you would score if you went through formal cognitive testing, because there appears to be a much stronger correlation of impaired cognitive function to the mood and the fatigue of the individual. So why is cognition important in cancer care? Well, as a physician, it's important because we are trying to, any patient that we have with cancer, we're trying to improve their health-related quality of life with our interventions. And cognition is one of the things, one of the domains of your overall quality of life. But what I've noticed in the neuroendocrine patients is that it has made me tailor the way we communicate with neuroendocrine patients, how we assess them, knowing that they struggle with certain aspects of cognition. The other reason is that it has been shown that cognitive impairment actually is prognosticating. This is just one of several studies. This is looking at hematological malignancies, and this is a survival curve. So this is the probability of survival over years. And these are patients that had normal cognition on their neuropsychiatric test prior to treatment versus the same type of cancer, same type of patient, and those that had some degree of cognitive impairment. So it is important that we learn to address this. So what is causing this? How is a cancer, a tumor, causing cognitive dysfunction? Well, the theory here is that the tumor itself has its own microenvironment. And within that tumor, we know now that there are a multitude of things that are going on, including inflammatory cytokines that are being released by the tumor cells themselves. And cytokines can affect neural cognition. They can also disrupt what we call the blood-brain barrier. They can get across through the blood system in and surround into the brain area. They also, investigators have wondered if the tumor itself is making some sort of substance that is getting into the circulation and circulating around. And in those of you with neuroendocrine tumors with endocrinopathies like carcinoid syndromes, you are well aware that your tumors produce peptides, hormones that we do know have a physiological effect. And maybe there's peptides that we haven't yet discovered. This is just to show you that there's a host of these cytokines we talk about. Most tumors produce these in various degrees, and these all, when they are directly put on neurons, will disrupt neurotransmission. A lot of cancers we now know have an immune response and will stimulate your T cells and your CD4 cells, and these inflammatory cells can also be neurotoxic. Here's a cartoon to try to sort of simplify what it is we're talking about. So we have this tumor that started in the GI tract, and it's producing these either cytokines or these vesicles that have these peptides in it. And if we blow it up and we look what's happening at the vascular level in the brain, well, some of those inflammatory cells are breaking through the blood-brain barrier and activating the glia cells, which are toxic to the neurons. Or maybe it's these cytokines themselves that can break through the blood-brain barrier and have a direct effect on the neuron and cause cognitive decline. Well, in neuroendocrine patients, I don't need to tell those with small bowel neuroendocrine the measurement of 5-HIA, which is the byproduct of serotonin. And serotonin comes from our dietary intake of tryptophan. So what happens in the normal patient without cancer? Most of your dietary tryptophan is being converted into niacin, vitamin B6, and a very small proportion then goes on to be made into serotonin. And we actually have in our bodies two compartments of serotonin. One is the GI tract, which makes up 90% of the serotonin, and the other is 10% of our serotonin is in our brain. But we must remember we have this thing called the blood-brain barrier. So what is going on in the brain is not always mimicked by what is going on in the rest of the patient. Well, why is that important? Well, serotonin in the brain is a neurotransmitter. We know it has been implicated in cognitive function. So how we alter the serotonin in the brain is important. So one of the postulates of small bowel neuroendocrine tumors is that this normal pathway of tryptophan going mostly into niacin is disrupted because now the tryptophan is being absorbed into the cancer cells, and 60% of our tryptophan is now being produced as serotonin that is released from the tumor cells itself. Now, that higher level of serotonin circulating, does that have an effect? We don't know. But we do know that serotonin induces more cytokine release, and maybe that's the effect on the brain. Or is it because now we have a relative tryptophan deficiency? Despite us eating well, a lot of our tryptophan is now being depleted by the tumor cells itself. And there was a good argument that possibly tryptophan deficiency was one of the reasons for neurocognitive decline in small bowel carcinoid syndrome patients, because we can create tryptophan deficiency by using a particular drug. And by doing that, we reduce the amount of serotonin that's produced in the brain. And this led to a whole host of cognitive impairment in those domains, that visual and verbal memory delay, visual spatial impairment, and difficulty with executive function. So Rusco in 2003 did a pilot project of patients with small bowel neuroendocrine tumors and carcinoid syndrome, and found that the cognitive patterns were different in the carcinoid syndrome patients than those of depressed patients. And they partially mimicked tryptophan deficiencies. They also found in their patients that they did have a lower level of tryptophan. So at the University of Calgary, we also were studying this at the same time, and we had a group of patients, 36 with carcinoid syndrome, and we compared them to 20 patients with non-neuroendocrine tumors that had metastasized to the liver using a battery of neurocognitive testing. And what we found is that the carcinoid syndrome patients had delayed recall, slower cognitive processing, and decreased mental flexibility, and that impairs your executive function compared to those with metastatic non-neuroendocrine tumors. We found that on patient-reported cognitive dysfunction, carcinoid patients reported much more cognitive dysfunction than their age-matched norms. And on formal testing, the reverse cognitive formal testing, the carcinoid patients had the most impaired cognitive dysfunction. So was that cognitive impairment in our patient population, was it related to the other aspects of cognition, sleep disorders, anxiety, depression? Very, very conceivable. Was it related to serotonin, or is it something else that's crossing the blood-brain barrier that we're not even measuring? Is it like Rusco thought, maybe it's related to tryptophan deficiency? Are these tumors producing some sort of neuroendocrine inflammatory process of peptides we have yet to measure at all? Or is it related to the somatostatin analogs? Because all of the patients that we studied were on somatostatin analogs. A lot more questions than answers. And that's why we tried to put together a study, and that's ongoing now, a prospective, open-label, multi-center, observational longitudinal study. And we're indebted to CNETS and Ipsen for the money to do this. I've partnered up with Rachel Goodwin, and we also have a team at the University of Western. And these three sites are looking to recruit patients with carcinoid syndrome and put them through formal cognitive testing before we start somatostatin analogs. Unfortunately, we are struggling with recruitment. The time commitment of several hours, a couple of times during that first year of doing cognitive testing has met many patients decline undergoing this study. We have screened 7 patients, and we have 2 that are active right now. I know Western has 1 that's active, and Ottawa has screened several patients, but has nobody that has agreed to go forward. So we then had to pivot a bit. We have this worthwhile question: what can we do? How can we look at cognition in neuroendocrine patients here in Canada? So we are running what we call a multi-center snapshot study, where we are looking at neuroendocrine patients' perceived cognitive function. So recognizing that it's not as good as doing formal cognitive testing, but it has a simplicity to it. And so we've been enrolling patients, and Ottawa and Western are just in the final stages of getting ethical approval. We're using a couple of study questionnaires that we think will give us the best results. And the first one is what we call the Frisbee Frontal System Behavior Scale. And it looks at executive function, disability, and apathy. And with the Frisbee, we also have a caregiver Frisbee. So significant others can also then participate in this study. We're also using the functional assessment of cancer therapy, or what's called the FACT-COG. This is a well-utilized and validated test that does look at perceived cognitive impairment on 4 different scales: the cognitive impairment, the cognitive ability, the impact of this perceived impairment on quality of life, and comments on other cognition factors from others. It's the simplicity of it that we hope that we'll be able to recruit a significant number of patients over the next year and have some real meaningful data from a Canadian multi-center trial. It takes about 20 minutes for the patients to fill out, 10 minutes for the caregiver. As the faculty member, it takes me another 20 minutes to enter and de-identify the patient's factors in REDCap, and then it has to be scored. So in summary, I hope I've been able to meet the objectives and bring some awareness to the issue of cognitive impairment, not only in neuroendocrine patients, but also in cancer patients. And I've highlighted the potential mechanisms and why I think neuroendocrine patients are unique and probably have some of these factors impairing their cognition. I also hope I've been able to highlight some of the ongoing studies that are being done in centers around Canada on this very issue. And with that, I would like to thank you for your time and attention. And I think that as a patient advocacy group, if you could support these types of studies, it would be greatly appreciated going forward. So thank you very much.